So, hi, Dr. Kevin. Thanks for joining me today. So we're just going to run through a few common questions that people might have about home care and, aging in place and a few questions about caregivers as well. So, okay, so why don't you tell us a little bit about, what is home care and how can people access it in our province of BC?
You bet. Thanks, Taya. It's obviously a bit of a passion of mine. I work full-time as a palliative care doctor here in Victoria. And so one of the goals of palliative care is to maximize patient quality of life. And so I'm often focused on what we can do to keep a patient comfortable. And in my experience, one of the things that's most useful is keeping a patient at home. That there are very few people that I'm looking after who are keen to spend more time in hospital than they have to. They usually see that as a means to an end and they want to be at home. And so the home care that exists in BC is a bit of a hodgepodge of public and private home supports that can come through the local health authority. There are companies that people can hire to bring in outside home care, or there's something like an app where people can find an individual home care provider to come and help look after them. In particular, we think about home care as the different potential levels of home care, and the higher levels of care, like something like a hospital at home program like we have here in BC, the home care nursing program that's provided through home and community care in BC, are all generally under the auspices of the public health system. That's something that's paid for by the government, funded by the government, and provided to patients generally at no cost to themselves under the Canada Health Act. What we're really talking about when we talk about home care a lot of the time is what is one level sort of removed from the actual healthcare or nursing care that people receive, and that's on the level of personal care. Sometimes this is referred to as home supports, especially by the health authorities, and they talk about that as being the care provided by healthcare aides or community health workers, and mostly revolving around the assistance with the activities of daily living. So these are the things that you need to be able to do every day. Commonly, there's a common sort of way of running off is dressing, eating, ambulation, transferring, so getting in and out of bed and getting to a chair or a walker or something like that, and hygiene and toileting, so being able to get to the bathroom and do your personal hygiene like bathing. Those things are the activities of daily living that allow a person to kind of live their life functionally, allow them to be at home. And that's not something often that the nurses will be there to help them with. That's what the healthcare aides and community health workers are really positioned to do. And I got involved in home care, especially because I see a lot of patients in hospital who don't necessarily need to be in hospital. They're not looking for new changes to their medications or the nursing level care that they need in hospital. What they really need is a little bit of personal care, like they can get from the home supports or private home care services. Yeah. And actually, even from before I was a palliative care physician, I was a family doctor, and I trained in Kelowna in the rural program and worked in Kelowna and throughout the interior for a long time. And actually, I think it's one of the things that a lot of rural settings do better than urban settings in BC, that they often have a tighter community, a smaller number of people involved, and that people can get, in many cases, better home care there because of the tightness of the smaller communities. So what I would call my best home care experience was actually when I was working originally as a family doctor. I was a locum doctor, meaning sort of a covering doctor in Grand Forks, BC, which is in the interior. And I had a patient then who was my patient who presented to the emergency department while I was there after a cardiac arrest. This was a gentleman who had had a heart attack at home, and then as a result of his heart attack, his heart had stopped, and his wife had actually taken a CPR class just a few weeks before, randomly, unfortunately, had taken the CPR class a few weeks before, so she started almost immediate CPR and called the local volunteer fire department, and the fire department showed up with a defibrillator and managed to defibrillate this gentleman and get his heart started again even before he had arrived in the emergency department. And in the emergency department, we provided some of the medications that he needed and then shipped him off to Kelowna for angiography and basically stenting to keep his heart from having another heart attack like that. When he got home, he required a fair amount of care. And so the community sort of rallied around this gentleman. He had been outside of the community for a while. And to me, that was one of the things that was most notable, was the fact that the healthcare system was almost in many ways the least responsible portion of what had happened to him, that the fact that his wife had chosen to take a CPR course a few weeks earlier, that this elderly gentleman's elderly wife was managing to give him CPR and keep enough of his blood flowing to keep his brain alive until the volunteer fire department got there to give him, to defibrillate him and restart his heart. And then the home care that he received after he got back, which was both from his wife as his primary caregiver and from other family that they had in the area, and then also from the official government home care services that we had in Grand Forks, all of that allowed him to get back on his feet and to live a long and productive life after that heart attack had happened. That's probably the experience where I realized just how little we're doing within healthcare, the actual portion that people are in the hospital, that people live about 98% of their lives outside the hospital, and that a lot of what matters is the stuff that's well beyond what we can do as doctors and nurses, and what other people do actually matters a lot more. So if I were thinking about one particular home care experience, that's the home care experience that I think matters the most to me, because it really drew the whole community together and really, led me to sort of feel quite significantly the burden on these primary caregivers, like this man's wife, who was, just fortunate enough to have taken that class a few weeks earlier. Yeah, and the first thing I'll say is the reality is that they don't have to choose one or the other. That what we usually see is a mix of public and private home care, that people will get basically as much as they can get through the public system and then supplement that through the private home care system. And the reason for that is really to do with a lot of the human resources shortages that we're seeing in home care in Canada, and honestly even across the Western world, about having too few healthcare aides to help look after people at home. Within the public healthcare system, the way that happens is somebody gets a discharge, say from hospital, or they get some kind of assessment through home and community care, and then they get a case manager who's usually a nurse, a registered nurse or an LPN, that assesses what their needs are and determines what they can provide through the public system. And one of the common misconceptions is that that's going to be free for the patient. It's not actually. In BC anyways, there's a copay associated with that. And so patients will have to pay something for the public home supports that they get. So even though it's from the health authority and from the public health system, the patients will still have to pay for that. Now, there are exceptions, and one of the particular exceptions that I deal with a lot is that a person who's registered for palliative care benefits doesn't have to pay for those home supports. But it's a common misconception, even amongst healthcare providers that I work with, that those home supports will be publicly provided and publicly paid for. It's not. They're publicly provided and still privately paid for. Those home support workers can come up, in general, are assessed and titrated or sort of adjusted based on the patient's need. But the maximum that the public healthcare system can provide is what we call QID, or 4 times a day home supports. So that means a healthcare aide coming into your home 4 times a day, say to help you get up out of bed in the morning and get breakfast, then to help you at lunch, then to help you with dinner, then to help you get back into bed. And the remainder of the time is based on family caregivers. That's what the family has to handle, all of that extra time. And often they are limited in terms of what they can actually provide, because they're not allowed to, say, lift patients for their own safety. They're not allowed to do things like prepare meals other than just heat up a meal that the patient's family has already prepared. So that's where it comes into play, that some people will decide to supplement those public home supports with private home care. The other factor that's challenging right now about public home supports, is that they are dealing with a staffing crisis, just like a lot of healthcare is dealing with a staffing crisis. And I've had it happen very, very frequently. The patients are coming out of hospital and saying, well, those QID home supports that I was supposed to get, well, actually, they were only able to come about twice a day. And the patient has no control over that. One of the challenges of a public healthcare system is that the patient isn't sort of employing or directing those home supports, and neither is their family. If somebody only comes twice a day, they've really got no recourse to go and say, well, actually, I need 4 times a day. And that private home supports really are one of the means that allow patients more control over that. So there's two real models of private home supports here in British Columbia. The first is sort of the traditional healthcare company, and there's a lot of companies that provide home care, lots of different agencies that will basically act as a staffing agency to supplement the home supports that people can give. Or the other model is for people to hire their own healthcare aide or their own anybody really that they want to have help them at home. And that can be them hiring a friend, that can be them just having a friend who's close and is a live-in, you know, if they need, say, housing, that can be a live-in caregiver. Or they can use an app or a platform like Gravity to help them find someone, a stranger that they don't know, and basically come to find a reliable trained caregiver for that. Most commonly, people are using that as a supplement to what they can from the public system, and it allows them a lot more control and allows them to direct that care towards the things that they need. So I mentioned earlier about the activities of daily living and that idea of dressing, eating, ambulation, transferring, hygiene, and toileting. Well, that doesn't account for somebody who might need help with their shopping or might need help with their housekeeping, or might need help with getting to and from appointments or a driver, basically. Those are not services that the public health system or the public home support system will provide. And those are things that people can arrange for a private home care provider, whether it's through Gravity or whether it's through privately or whether it's through a different home care agency to allow them to have someone to do those extra things that the public home supports won't provide. Most commonly, what I've seen is that people want the home supports to work really well, and I wish they did work really well, but in my experience, people are often sort of having high expectations when leaving hospital, and then often becoming disappointed in the level of home supports that they can receive, not because the home support workers aren't good, they're very good at what they do, but I think they're just overwhelmed, and the system is too strapped with far too many patients or far too few people to be able to see.
Yeah.
So the first and most important people that I always talk about are the patient's family or chosen family sometimes, if it's friends or other people that help to look after them. The fact is that in the way our healthcare system works, there's a lot of people out there who don't have a lot of medical treatments that are available for the things that are bothering them. So in particular, the two fundamental things that we see a lot of are aging and frailty and cognitive impairment. So that's sort of a physical decline of aging and the mental decline that sometimes accompanies aging, but doesn't always accompany aging. And there are not a lot of medical treatments available for cognitive decline or for frailty. A lot of the time it's about changing someone's environment and changing the supports that somebody has to allow it to meet what they are able to do at that point in time. And that burden is often placed on the patient's family and friends to help support them through that time. Doctors and nurses are involved, but if there's not a medication or some sort of treatment for the thing that's happening to them, then all we can do is make recommendations and say, well, you know, they need a supportive environment, they should stop driving, so that means they need some other way of getting around. For someone who's frail, we can recommend a cane or recommend a walker, or recommend a hospital bed. But all of that burden eventually gets placed on the home care system, and in particular on the family caregivers that are providing most of the care around you. In addition to that, there's often sort of acute exacerbations, and that's where the medical team really comes into play. You know, when somebody has these acute exacerbations of their chronic conditions. So, you know, if somebody is feeling worse because they have some recent infection, and often that can involve a visit to their family doctor first. If they're in a more urgent or emergent situation, that can involve a visit to the emergency department. And in all of those cases, that's where the medical system really has a great role to play, is in dealing with these acute events. And in terms of prevention and trying to basically manage, say, somebody's blood pressure, trying to provide medications that limit the progression of cognitive disease. We're trying to make recommendations for somebody to continue exercising or keep their lung function or heart function up to allow them to continue to mobilize. But it's really more about prevention and about treatment of acute events. The actual management of those chronic conditions comes down primarily to the family caregivers. And it's when the family caregivers need that extra help, when they need the home support, that's where the home support system comes into play, because it really depends on the patient population that we're looking at. I mean, I work in palliative care, and palliative care is somebody with an active condition that's leading towards the end of their life. And most of the time that has to do with sort of a cancer or an end-stage organ failure like heart failure or pulmonary fibrosis. But commonly, the people who need care over a long period of time are not the ones who have, say, an active malignancy like cancer. They're patients who are frail, who have some cognitive impairment, who have difficulty looking after themselves and need more and more help over time. And that's really where family caregivers can become stretched, because we're not talking about sort of a short-term sprint where somebody needs somebody there 24/7. We're often talking about a marathon where somebody can be getting sick over years or even decades and need a lot of support for that time. And it's really straining for families. And one of the things that I hope to do with Gravity was to provide that extra support so that family caregivers can go back to being family and less caregivers. And the care providers can take some of that weight and allow people to be, I guess, caregivers, but not to burn out and not to suffer the consequences of providing all the care more than they can provide.
Yeah. No, Gravity is, I think, instrumental in providing caregivers with the respite that they need for these situations. Okay, I think
you mentioned earlier. You mentioned earlier that notion of like the HCAs being kind of the eyes and ears of the healthcare team, and I absolutely agree. Like they're there, to help the family caregivers to be there and to be present and to help with, dressing, eating, all of those things. And also to recognize when something is different from their usual baseline, that people are often, I see patients managing just incredible situations in order to be at home. But it's up to the HCA. Often it will be the person who recognizes like, this is not how they usually are. They're off from their usual baseline. They're more short of breath. They're more frail. They don't usually stumble like this. And those are the sorts of things that can trigger, either a family doctor visit or a visit to the emergency department, or in the case of my patients, often an admission to the palliative care unit or hospice.
Mm-hmm. Yeah. Okay, well, great. Thank you so much for answering these questions, and we'll see you in the next Ask Dr. Kevin series.
Okay, thanks, Taya.